Yali Madad, everyone. I welcome you all to this very educational talk we will be having today on behalf of Aga Khan Health Board for Northeast. My name is Sana Somani, and I'll be moderating this session. I'd like to start by mentioning some house rules for this presentation. I request everyone to mute themselves starting now. If you don't, our admin can also do that for you. And this is, of course, only temporarily. At the end of the presentation, feel free to unmute yourself when we are taking questions because this presentation is for you, so your participation is very much appreciated. If during the presentation you have any questions, please post it to the chat and I'll make sure to take a note of it to be asked later. And now I will start by introducing our honorable speaker, Dr. Salima Qamruddin. Dr. Qamruddin completed her medical school from AKU Karachi and then moved to the US to complete her residency and fellowships. She currently serves as the director of the Women's Cardiovascular Wellness Clinic at Ochsner Heart and Vascular Institute in Louisiana. And her work in women's cardiovascular wellness revolves around raising awareness through media and lectures and utilizing novel technologies to prevent heart disease prevention in women of all ages, with special focus on heart attacks in women with preeclampsia, breast cancer survivors, and those in menopause. And today she will be discussing cardiovascular disease for women. That's why I'm wearing red here. Go red for women heart disease.
Right.
And with that, Dr. Kamruddin, the floor is yours. Thank you.
Thank you. Hope you all can hear me. Thank you, Dr. Samani, for such a nice introduction. Yalimada to all of you. It is an immense pleasure to be able to deliver this talk, something that's close to my heart. I have been assistant professor at Ochsner Medical Center in New Orleans for the last 10 years. I'm currently the endowed professor of mentorship at Ochsner. I did start the Women's Heart Program. The bulk of my technical profession is reading ultrasounds in a dark room. But in 2020, I decided to build a women's heart program here that has been immensely successful, and I think it's needed. So I'll share my journey and what I've learned in the last 5 years with you all. I think the first thing I'm going to tell you is that heart disease is the leading cause of death in women in United States. And when I use the word heart disease, it's not just heart attacks. I'm talking about congestive heart failure, which is a rising epidemic in older women 60 plus, and the incidence of heart valve disease. So, heart disease encompasses all these things. It's not just heart attacks we're talking about. There are almost 300,000 deaths in 2019 due to cardiovascular disease. 1 in 5 women die of heart disease, and it kills 4 times more than breast cancer. Above the age of 65, it's actually 6 times more than breast cancer. And the reason to bring this up is you can imagine the amount of awareness around breast cancer that we have. Must get your mammogram yearly, right? To prevent breast cancer. We do not have similar campaigns, or the campaigns that have been started 2 decades ago have not garnered the kind of attention that we need for women to understand that they are at risk for heart disease, and it's equal as impactful, or as the leading cause of death in men and women both is heart disease in this country. It's just not gained the kind of momentum they would like for large campaigns for women to be aware across US that heart disease in fact is the number one killer. In fact, 35% of all total deaths in women in 2019 is due to cardiovascular disease. So it is the number one killer. It does kill 1 in 5 women. And it is important to know that healthy young and pregnant women also suffer from heart disease. It's not just the older women. There is in the US currently a rapid rise of heart disease in young women. Part of it is the higher incidence of obesity that we're seeing across the country. That is the cause of this. There's more diabetic women now in their early 20s and 30s compared to the past. Why is it that first of all, these stats are alarming that heart disease is so rampant, but the awareness is not there? There are plethora of reasons why that is the case. Well, number one, if you look at all the research that has been done in heart disease in the past 4 decades, starting in 1950, where the cardiac bypass was first started, followed by the era of clinical trials, where there was a lot of evidence-based research that came out, which is mid to late early 1980s. If you look at all these trials, the drug trials and the device trials in cardiology, you see that women represent less than 20% of all these trials. In other words, we don't know if these drugs and these trials really work for women in terms of outcomes, which is a big part of the problem. So, currently, even as of today, clinical trials are only enrolling about 30% of them being women, and the American Heart Association has taken a very strong stance against this. And I think all pharmaceutical drugs currently are being asked to enroll more women. Part of it is, pregnant women were never part of any clinical trial. So we don't have that data, which ethically seems correct. But having said that, there is just not enough data about heart disease in women. Women are not smaller men, right? So our hearts are also very different. Our hearts are smaller, our arteries are smaller, but there is not enough research to understand what is happening to a woman's heart and why are we having heart attacks? Are they the same or not? So this talk is going to be focused on understanding what are some of the sex-specific risk factors that are inherent to women. What we have learned in the last 2 decades is that there is something inherently connected to heart disease and its relationship to onset of menstruation and a cessation of menstruation, which is menopause. There's something in that life cycle, starting from menstruation to menopause, from menarche to menopause, what the medical term is the fact that once the estrogen is cessates, or you don't have enough estrogen in the body, it appears to have some profound effects on cardiovascular health. It has profound effects on the vascular tone of the heart. It has profound effects on blood pressure and the risk of heart disease. In other words, once you have menopause, the risk of heart disease as a blanket statement goes up. Now, women who have menopause early, if they're especially before the age of 45, whatever that reason may be, tend to have more risk for heart disease. You'll see as I'm going to explain this further on. What we now know, and this data is still fairly new. I would say it's less than a decade new. That it's not just the traditional risk factors of heart attack that we know of. It's we think of when we think of heart attack. When classic textbooks always show a man who's shoveling snow, going up a high hill, and suddenly clutches his chest. Or if you've seen our Bollywood movies, it's always the guy who hears bad news and clutches his chest, and he's having a massive coronary, right? Um, the risk factors that are traditional we know all about is high cholesterol causes heart disease, and we almost always think of heart attack when we think of heart disease, but that is just one spectrum of heart disease. Diabetics, patients who have high blood pressure, smoking, and a sedentary lifestyle. In other words, you're just not active, not putting 5 to 10,000 steps, or exercising, obviously would be considered the traditional risk factors for heart disease. What we now know is that women tend to have certain risk factors that affect their heart condition later in life. That includes conditions in pregnancy. And if you have high blood pressure or diabetes in pregnancy, I actually know people in the Jamaat that have high blood pressure in pregnancy, young women. If you look at their 10-year risk of heart disease, it's substantially high, both the risk of congestive heart failure and acute heart attacks later in life, and they tend to have a heart attack earlier than their counterparts. The other important risk factor is PCOS, and we'll talk a little bit more about these. So here are the traditional risk factors. Almost, diabetics tend to have very high risk for heart attacks. High blood pressure, we know that. In fact, unfortunately, women, the risk of heart attacks and strokes with high blood pressure, and this has been shown in several large databases, have more risk of heart attacks and strokes in the setting of high blood pressure compared to men. At menopause, there appears to be a sharp increase in your total cholesterol. and your bad cholesterol, as well as the triglycerides, or the fat in the bloodstream. And often statins are underutilized. Women are prescribed statins less than men, unfortunately. And so the risk of heart disease is high in women at menopause. Continuing on the traditional risk factors, we know that smoker women actually have 3 times more high risk for cardiovascular disease compared to men smokers. And then we'll talk a little bit about a family history of premature coronary artery disease, which, if you have a family member that had a heart attack, a male family member typically we know of that has a heart attack before the age of 50, and in women it's before the age of 60, is considered premature. And potentially there is an element of genetic transmission, whether it is via increased cholesterol synthesis in the body, or it is because you've got other genetic biomarkers such as high lipoprotein in the bloodstream that increases the risk for heart disease. Now, what's specific to women? Let's talk about that. One thing is premature ovarian failure, and what that means in non-medical terms is somebody who stops having their periods in their 40s. More concerning if it is before the age of 45, and there can be multiple reasons why that happens. Polycystic ovarian syndrome is present in 10% of women, and it is a cause of infertility, causes increased risk for diabetes and high blood pressure and weight gain later in life. Typically seen and starting in more common in women who are overweight because of the production of excessive androgens in the body. PCOS increases the downstream risk for heart disease by 2 to 3 fold. Um, Premature ovarian failure, stopping your menstrual cycles. Who do we see it in? We see it in women who are breast cancer survivors, especially those that are estrogen positive breast cancer survivors, where they're given estrogen analogs, estrogen receptor blockers. What ends up happening is they completely stop their periods, especially breast cancer women who have had breast cancer in their 40s and have had estrogen receptor blockers. They are at high risk for heart disease, and we'll talk a little bit more in detail with that. Autoimmune diseases also cause premature ovarian failure, and there are some that are idiopathic. We don't know why the ovaries fail. PCOS can be one of them, but there are times when we unclear why the ovaries fail. But if they do in their 40s, that increases the risk for heart disease. I alluded to this a little bit before, is high blood pressure in pregnancy, which unfortunately in United States is currently at 7 to 10%. 7 to 10% of all pregnant women develop high blood pressure in pregnancy. So the first thing I would suggest is, if you hear someone who is really feeling unwell during their last stages of pregnancy, they're having headaches, they're having more shortness of breath, then would be required in the last trimester of pregnancy, they should get checked for high blood pressure. It is getting more and more common to see women with high blood pressure, and it's, the clear risk factors for those we know are being overweight is a big one. Diabetes is a big one. But there are other environmental factors, frankly, that it's just not known as of now why this is happening. But it is much higher than the rest of the developed world, including Canada, which is only 1%. So it's a major cause of heart disease later in life. So understanding, and I know friends in the Jamaat that have high blood pressure during pregnancy. It is really important not only to treat the high blood pressure in pregnancy, but post that to be able to be counseled for how heart disease can be reduced. Similar situation is gestational diabetes. If you develop diabetes in pregnancies, this is more common in the last trimester of pregnancy. Two things happen. One is you have more lifetime risk of developing diabetes. And secondly, you also have more risk of developing heart disease, even if you do not develop frank diabetes later in life. We have a lot of older women in our Jamaat that have rheumatoid arthritis. It's an inflammatory condition. Heart attacks also cause a lot of inflammation in the arteries. So we know that women who have inflammation, as such, all autoimmune diseases are 10 times more common in women than in men. But if you have rheumatoid arthritis, you can have accelerated plaque built up into the arteries and more risk for heart attacks. So risk stratifying, trying to figure out if you're at risk and how you can reduce that risk is really important. Let's talk a little bit in detail about breast cancer survivors. Unfortunately, breast cancer survivors have 10 times more risk of dying from heart disease from any other disease. This is true for estrogen positive breast cancer and estrogen negative breast cancer as well. And why is that? When women get breast cancer, especially left-sided breast, two things happen. One is, your breast cancer may be removed by surgery. The common scenario is it's removed by surgery followed by chemotherapy and radiation. The chemotherapy that's given to the breast is toxic to the heart. Okay. Now, everybody does not get toxicity to the heart. It is dependent on what the underlying substrate is. In other words, if you're somebody who has strong family history of heart disease and now you're developing breast cancer, your chance of developing toxicity to the heart is higher than somebody who does not have any history, is not a diabetic, does not have high blood pressure, does not have abnormal cholesterol panel. Those young women will do better with chemotherapy than women who have some kind of underlying risk that is there. So what can you do? Okay, so if one ends up getting breast cancer and does have abnormal cholesterol profile or has stage 1 hypertension, they are better off being started on cardioprotective agents or blood pressure medicines that reduce the incidence of heart disease later in life. Secondly, the radiation that's given to the left side of the heart, that radiation directly affects the buildup of plaque in the arteries of the heart, as well as it affects the heart valves. It causes early calcification of the valves. Now, this is specific to the left breast because the left breast is sitting right over the heart, right? So even though the mantle radiation is trying to seclude all of the organs, but it does, because it's overlying the heart itself, the heart gets irradiated, and that has these effects start showing up at 10 years after breast cancer has been diagnosed. So the recommendation is that 5 years after breast cancer has been removed and you've received radiation, you do need to get screening of your heart and see if your heart's actually starting to take effect, whether your heart valves are starting to get diseased or you're developing early plaque into the artery. So one of the recommendations for women who get radiation to the left breast is to get a treadmill stress EKG at 5 years. That's standard recommendation. Um, all right, next talk about what are the symptoms of heart attack in women. So the first thing that is sort of very sad, and this is partly why I started doing women's heart health, is there are so many biases in the way we not only treat but understand heart disease and how women are being taken care of in the emergency department that can be extremely disheartening. So I want to talk a little bit about it is more likely that a woman going in the ER with chest pain is going to be considered non-cardiac. In other words, it's not the heart, it's something else. A 45-year-old coming in may be told that she's having a panic attack. It's very common to hear that. And now, thanks to certain experts at the American Heart Association, this has actually made it into the guidelines for American Heart Association to make the point that it is very important that when a woman presents with chest pain in the emergency department, she must be ruled out for an acute heart attack. In other words, she is going to get an EKG and other testing that's needed. I have been very lucky to be able to speak on this in a BBC story, which is about a young woman goes to the emergency department in Atlanta, and a very prominent, and she's a HUD attorney in New Orleans, and goes to a very prominent heart and vascular institute. Is told that her chest pain is wedding jitters because she's there for a wedding, and she waits 12 hours in the emergency department before she's taken seriously. This is a classic example of despite having risk factors, the way we think about chest pain and heart disease or heart attack is it's all about what are the underlying risks. Having said that, I have seen a number of women that do not have a lot of risk factors and that come in with a classic traditional heart attack. So the first thing I'd say is that if you are experiencing pressure on the chest or chest pain that just seems very unusual, you must go in right away. And the reason for that is the kind of symptoms women have during a heart attack are completely different from men, and quite sort of distinct. Women tend to experience a lot more nausea, vomiting. I have had several women explain to me that they feel like there is a band of pain that's going all the way to the back. This is not a traditional classic chest pain that you'd hear from a man who speaks about, I have heaviness in the chest, it's going to my arm and my jaw, and I just can't breathe. Women tend to talk more about being nauseous, or I just threw up and I have this band like pain. The sad part about this is I have seen several women now in my 5 year career of focused on heart disease in women is that they do not come to the emergency department, and they wait, and they come back a week later or 10 days later because they're still feeling the pain, and now it's too late. The heart attack is already completed, the scar is already there in the heart, and the heart function has reduced, which obviously leads to other complications of the heart such as congestive heart failure. So it's important in the community for you and your friends to understand, first of all, heart attacks can happen in young women. It's not just a disease of elderly women. I'd like to point out that typical traditional heart attacks we see in men are typically in their mid 50s to mid 60s. Women tend to have heart attacks about a decade later. So we see more women with heart attacks in their mid 60s, but there are now a rising epidemic of heart attacks in young women that are seen in this country. So it is very important, and we're going to talk a little bit about the types of heart attack in women in the next slide. So important to understand, heart attacks in women is more accompanied by nausea, vomiting. There's still chest pain or pressure. Now, the thing that I would like to point out that the pain from the heart attack is less of a pain and more of a pressure. You feel like somebody's sitting on your chest. You need that person to get off. You feel suffocated and you can't breathe because of the depression of the heart function, the fluid building up in the lungs right away. You just feel very short of breath along with that. Those are the classic things you need to remember. Very occasionally, we'll see somebody who's talking about fainting, or we'll talk about fatigue. I just feel really, really low. But most of the time, there is chest pain, but it's accompanied more with GI symptoms. So, what is a heart attack? And this is important because it kind of gives you a perspective of how heart disease may be different in women. This is an example of a traditional heart attack. The patient goes in, is having real bad chest pain. The first thing you do is get an EKG. It looks abnormal. You immediately take him for an angiogram, and you see that this particular artery, in this case, this is the left circumflex artery. You see that there is a huge blockage there. The blood's just not flowing. In this case, this is contrast or dye that is trying to light up the artery, and you see that this is a focal lesion there, an atherosclerotic lesion that is causing a complete cessation of flow, and then it's filling up, but it's filling up more sluggishly than proximal to it. This is a traditional heart attack. We see many men with this type of heart attack. Now, there is a rise of heart attack in women, but what is important to understand is almost 30% of the women that have heart attacks are actually less than 50, which is very alarming. And this is a growing trend, unfortunately, going in the wrong direction. What we see with women's heart attack is a common type of heart attack we see in women is called a SCAD, which means that it's actually a tear in the wall. It's not a focused blockage. All right. They may have blockage, but it's more to do with a tear in the wall that can cause similar symptoms. And you can see because of the tear, the blood is not filling in that artery. This type of heart attack is seen right at delivery or right before delivery. It is common in women who have high blood pressure during pregnancy. It is common in people who have any kind of connective tissue disease. In other words, if you've seen or heard of people that have diseases like Marfan's or Ehlers-Danlos, which is a problem with the tissue, the kind of the cement of the walls that is deficient, That is what causes this kind of thing. Recently, we know that infertility treatments are increasing the risk of SCAD. Now, I will tell you that this data comes from UK Biobank, and it's still very early to say it's a real causative. I mean, a lot of these studies that I'm describing, unfortunately, in women's health are retrospective data. We only have a hazards ratio. It's unlikely that we're ever going to get a positive, prospective, randomized trial on this. But the bigger the database gets in retrospective data series, the more cogent the association becomes. And I know that the data that I'm describing, a lot of it has become bigger and bigger over the years. In other words, when we first started looking into this from a research perspective, there were 20,000 people. Now it's 40 or 80,000 from a bank or from retrospective databases that has been shown that, yes, infertility treatments, which are very getting common as older women are getting pregnant, is a cause of SCAD. And this is typically happening right before delivery or right at or post delivery. So if you know of a family member or a friend that is having chest pain right after they delivered a child, this is something that has to be taken pretty seriously. Now, certainly there are illegal drugs like cocaine has been implicated in SCAD and long-term use of steroids because the steroid use that we see, for example, in rheumatoid arthritis and certain other autoimmune diseases can cause thinning of the walls of the arteries. The other type of heart attack that's common in women, it's called minoca in the medical terms, but what it really means is you're not having a traditional heart attack. In other words, you're not having a blockage of a big artery, you're actually having blockages of these small arteries of the heart. So these small arteries that we would call the microvascular system of the heart, or the tributaries of the heart from the epicardial coronary arteries, are the ones that are getting these small blockages. And this has been shown nicely by a group in Pittsburgh with MRI data that the heart attack is the same, but you do not have blockage in a big artery. The treatment for this type of heart attack is also the same. In other words, you do need cholesterol lowering medications, you do need blood pressure medicines, you do need beta blockers to reduce the incidence of congestive heart failure. This is as much as 15% of heart attacks in women that are young. So the take home point here is you may get an angiogram, you're having a heart attack, the doctor may come out and say you do not have a blockage, I don't see it. Well, the next step is actually to get a PET or an MRI because you want to know if you actually did have an infarct or you do have an area of the heart that is scarred. And that requires more sophisticated testing. So look up Minoka and look up the data that's coming out. I think it's very promising and I think it's expanding. At the next 5 to 7 years, we're going to see more data on this. Um, Let's talk about menopause. Okay, so are there cardiovascular effects of menopause? And the answer is absolute yes. There are some changes in the cardiovascular system that happen because of menopause, and primarily it's related to the loss of estrogen, which traditionally has been thought to be protective of heart disease. Once the drop in estrogen will cause a rise in blood pressure about 6 to 10 points, it does cause high cholesterol. So you'll see a lot of women will have high cholesterol 2 years before and 2 years after menopause. It is actually related to menopause itself, which increases not only the total cholesterol, not only the bad cholesterol, the LDL, but it also increases the triglycerides. Both the LDL and the triglycerides confer increased risk of heart disease. There is also increased prevalence of metabolic syndrome. In other words, there is something about these changes that slow the metabolism of the body. So, with that comes weight gain. With that comes a rise in blood pressure. And in some women, we'll see glucose intolerance. In other words, they are not frank diabetics, but they start to have difficulty digesting the carbohydrates. So they have more sugar in the body, and that leads to other effects like increased triglycerides. So high carbohydrate diet in the postmenopausal women is going to cause more high triglycerides or fat in the bloodstream. Palpitations, common problem, happens all the time. We'll see a woman who is right at menopause, and there's a frequent cause of cardiology consultation because they will complain of fluttering or pounding in the chest, loud or racing heartbeats, skip heartbeats, an uncomfortable awareness of your pumping heart. So I have seen innumerable women during my 5 year career in women's health about men related to menopause. And I will say that for one, it's important to know that this is but normal, as something to do with the fluctuating. The hormones fluctuate a lot right before menopause or a year before it, where the estrogen goes up and down, and estrogen has profound effect on the electrical system of the heart. It stabilizes the electrical system. So as the estrogen drops, you will get the fluttering, and then it rises and the fluttering comes down. So a lot of times these fluttering or palpitations are transient. They do not happen, continuously. I would say if this problem does not go away, or it's not a few days, you'll have women usually complain, this, it happened this month, is really bad. I was having these pounding in my heart that lasted few seconds to few minutes. It went away, but this month it's not happening at all. If it's something very transient, I think it's important to recognize that it may be menopause related. I will say it's also related to the symptoms of menopause itself as well. For example, lack of sleep is a big problem in the perimenopausal women. Um, if you're having a lot of either lack of deep sleep, or you're having insomnia where you just can't fall asleep, then your sleep is very disturbed. Sleep is very directly related to palpitations, because when you do not sleep adequately, the stress hormones of the body are high. So your cortisol and estrogen is higher in the body. Not estrogen, sorry, epinephrine is high in the body. Those tend to cause a lot of instability of the electrical system of the heart, and they stimulate the heart. So sleep has itself, irrespective of menopause, has a direct effect. So, you know, we also get a lot of skip beats during menopause. Now, all of that, women are who are consuming a lot of caffeine in that time period, having lack of sleep, you know, caffeine to compensate for lack of sleep, perhaps all that is then adding to excess cortisol in the body. Then that is sort of becoming this vicious cycle of having more fluttering or pounding in the chest. So trying to uh, appease or calm down the symptoms of menopause that do include insomnia, brain fog, arthritic symptoms, fatigue. If you're experiencing those, my advice to you, first of all, is going to be, if you're otherwise a healthy woman going into menopause, there is nothing wrong with getting, menopausal hormone replacement therapy, because from all the data that I have read and understood, it appears that it has good long-term benefits, especially on bone health, which I think a lot of our Jamaat suffers from osteopenia and osteoporosis. Part of it is, we've inherited that from our grandparents. It is very reasonable to be treated with hormone replacement therapy during menopausal symptoms. But obviously, hormone replacement would be contraindicated, and it's contraindicated in certain breast cancer patients. It is contraindicated in certain heart disease patients. We do not give hormones to women who have had heart attacks or have had stroke. Now, those are very unfortunately, from the data we currently have, which is evolving, and hope it evolves further. But from the data we have from the Women's Health Initiative, we know that those in the older women, especially as they continue to take hormones, it confers more risk of heart disease. What about atrial fibrillation, which is an abnormal heart rhythm of the heart that increases the risk of stroke? We do tend to see this in older women. There is not a direct relationship to menopause, but we do seem to see it in older women, which is 64 and beyond. And we think lack of sleep, or disturbed sleep and stressful life events appear to increase the risk of atrial fibrillation. I would say the data on premature menopause, if you your menstrual cycle stopped before the age of 45, there is very strong data that increases the risk of atrial fibrillation. It's been shown in multiple studies that that is the case. So keeping that in mind, that there is something about the healthy life cycle, menstrual life cycle of a woman that appears to be intricately related to the risk of heart disease. Obviously, AFib, atrial fibrillation, is related to increased stroke risk, but is more common in women who have high blood pressure, who have diabetes, who have other vascular disease, like they have blockages in their leg arteries or have had prior stroke or mini strokes. In those women, the risk of atrial fibrillation is fairly high. I would say here that it is very plausible to find body wearables that can detect atrial fibrillation. We've got I put the Apple Watch, but now I should have put some other body wearables as well. One of them is called iCardia, which is actually like a little credit card like wallet, and you can put your two thumbs on it and it'll give you the regular continuous EKG, which will tell you whether your heart rhythm is regular, whether you have skipped beats or you have AFib, and you can send this data. You can record this data and send this directly to your physician. I get these recordings all the time. Some health systems are trying to integrate this into their health system so that you can get all the data directly from Apple. And actually, I'm part of that team to try to understand how we can integrate this into the charting of the patient. Now, the new Apple series is actually showing data that it can detect high blood pressure, which is fantastic. So if your blood pressure readings are starting to get high, it's worth a visit to your doctor to say, hey, am I developing first stage high blood pressure? And like I mentioned, a lot of women at menopause will see about a 6 point rise in their blood pressure. Having said that, if you're somebody who's sort of like early stage high blood pressure, you would start to see that your blood pressure is now in the 140 range. And depending on your risk factors, we target blood pressure slightly differently. If you have premature heart disease in the family, and if you do have hypertension, if you do have other risk factors, then certainly we want your blood pressure to be even lower than that, 135 or so. So body wearables, whether it's Fitbit or an Apple Watch or it's iCardia or some other Whoop, things that will give you your data that empowers you is probably very useful. Early diagnosis is the key. So the first thing is if you have an access to a professional, what you want to see is you want to see a preventive cardiologist. You want to ask, hey, am I at risk for heart disease? My dad or my cousin had, heart disease in their 60s. What do I do to get better? So some of the things we do in our screening clinic is one, we offer a test called a calcium score, which is a CAT scan. You go in the CAT scanner and they take one picture of your heart, and we're looking for this early buildup of plaque. Now, I will say that in young women, the plaque is often soft, and we may not be able to see the plaque really strongly, but we may be able to do other things such as order an LP little a, which somebody asked us in one of the questions. It is a genetic biomarker. It's a lipoprotein, which is not tested in your standard lipid profile. We know a lot now about LP little a, and we know that the LP little a um, is sort of designated at birth, and it is elevated in 20% of the population. And if it is, it increases the risk of heart disease, stroke, and aortic stenosis or valve disease. Currently, we have no drugs on the market that actually treat LP little a. So if you're a young person, you've got family history, your cholesterol's overall okay, your lipids are not, your calcium score is not that bad, but your LP little a is very high, we do recommend lowering the cholesterol further because part of the reason we prescribe statins is it will stabilize the plaque, not just to lower the cholesterol itself. And then there are certain other inflammatory markers that we check that would also, we know, confers risk of heart disease. So what we do with this information is if your score is really high, in other words, you have a lot of plaque built up, we will recommend either a statin or lifestyle modification, we do not repeat this task because with aging, the plaque is only getting worse. So we don't say, oh, let's do one, we'll do another one in next year. No, we typically will repeat this in young people in 5 years only if they don't have any plaque and the history is pretty strong and we want to decide if we're going to treat them with statins, we may offer them another calcium score at 5 years. So, prevention is the key to women's heart health. The American Heart Association recommends what we call a pesco Mediterranean diet, which is lots of fruits and vegetables, some healthy olive oil, nuts, some fish, less dairy, less meat, less alcohol, less sugary drinks, less white sugar and white flour, right? So I would say a general principle would be that all your meals should have vegetables in it. That's probably the bulk of it. And, from our Indian cooking, where we have so much lentils in our diet, which is fantastic. Um, but having vegetables with every meal is what's needed. I think for our culture it's more limiting the amount of oil we use in our foods is probably more essential. This diet, the pesco Mediterranean diet, is not just endorsed by AHA but actually by CNN poll and multiple other observational studies. It's been shown that it's one of the best diets in the world. um, so I would suggest that healthy starches are okay. Breads that are more wheat versus white are okay. It's to limit the carbs in the Mediterranean diet are much lower. It's much more focused on fruits and vegetables and hearty vegetables. The broccoli, the eggplant, cauliflower. It's the bulk of hearty vegetables that should be part of every meal, including the lentils. Um, the other thing that I wanted to point out, and especially related to menopause, is, we all hear about American Heart Association says, 150 minutes of exercise per week. But it's important to recognize that women rapidly lose muscle starting in their 30s, but it is almost a 30% uh, muscle loss at menopause. And what happens was that is weight gain is very easy. And why is that? In very simple terms, if you think about a fat cell, one fat cell will burn less calories than one muscle cell, right? One muscle cell will burn about 9 kilocalories and one fat cell will burn about 4 kilocalories. So as you lose muscle, your metabolism really goes down, right? So with that, it's so easy to gain weight because you're eating the same amount of food, but the body is burning the food at substantially lower rate per minute. So the food is the same, the intake is the same. You may have actually reduced your intake because you're gaining weight, but you're not gonna cause weight loss because of that without building muscle. And this is a huge problem in perimenopausal women, and fighting this is really hard. Now, I'm gonna talk a little bit about how to strength train. I am not suggesting that you head to the gym and start picking up 30 to 40 pound weights today. Don't do that because that's going to hurt, right? What I am suggesting is that, you will start with strength training very gradually, starting at, 5 pounds, 10 pounds, getting a personal trainer to try to understand how to use gym machines if you're going to do that, or how to lift weights without, hurting your back, which is a very common problem with weight training. It's about doing these gentle start to train and understand that strength training should be part of women's heart health. Um, Whether it's yoga, Pilates, yoga with weights, Pilates with weights, a reformer, all wonderful. Swimming is wonderful because gives you a lot of resistance and builds muscle. I can't speak of supplements that can aid muscle building. I can't speak of that because that's not currently endorsed by American Heart Association. I can't speak of supplements otherwise that are needed. I think for menopausal stage, I think one multivitamin a day is what's recommended. But having a holistic food where you get all your vitamins and essential minerals is probably really important. I will leave that up to other physicians who can speak more on, healthy building of muscle loss. I'm not an expert in what supplements could be used. I know none are endorsed by American Heart Association. I encourage you to read this book called Women's Heart Health, which is actually a very small, easy to read book. And it gives you most of the points that I talked about, but it kind of brings to light how much we can do to improve our heart health. This is an interesting study, and I do recommend reading this book. It's available on Amazon and other sellers. Prevent and Reverse Heart Disease is a surgeon, Dr. Colville Elselstein out of Cleveland Clinic, who was actually a breast cancer surgeon and kind of got really tired of, seeing a lot of breast cancer and somehow meandered into heart disease. And one of the trials he did in the late 90s, which is really a seminal trial, showing that, he put his patients that were refused a cardiac bypass because they were bad diabetics, they had bad heart disease, they had poor heart function. The surgeons did not want to take them for surgery because the risk for surgery is really high. They put these patients on a whole food plant-based diet, and his famous line is anything with a mouth or a mother you cannot eat. In other words, he basically said no meat, and no oil. Very strict. But he was able to show in a clinical trial that, in fact, you can completely reverse these plaques by being on a whole food plant based diet. Now, the American Heart Association never endorsed this, despite that it was a randomized clinical trial. I think I cannot speak of the reasons, but I think ultimately it's about keeping a balanced diet. And there's a lot that you can achieve by staying mostly on a plant-based diet. Bulk of your diet being plant-based actually does make significant improvement both to heart and brain health, in fact. Um, so I will end by saying that it is the number one killer in women. And when I say heart disease, I just don't mean heart attacks. One of the things I did not speak about, and I only realized that after building up my slides, I want to take a few minutes to talk about is congestive heart failure. We see a lot of older women who have had high blood pressure for 10 or more years, starting at 60, and then they'll come in with congestive heart failure, which is the type of heart failure where the heart pumping function is normal, but the heart does not relax. This condition is very common. And so you can start preventing that by delaying the stage or age at which you develop high blood pressure. The more you can push out the age where you first develop high blood pressure. 1 in 3 people above the age of 65 in the United States have high blood pressure, right? It's a lot. So staying healthy, if you can continue to exercise, stay on a very low salt diet with a plant-based diet, you can actually push out the age you first develop high blood pressure, which reduces the risk further of developing congestive heart failure. A lot of women, the cause of death in older women is congestive heart failure, is the fact that the heart does not relax. It's a very difficult to treat condition. We don't have enough drugs. We don't have enough data to understand why this happen, unfortunately. But it's a huge problem, and we have another probably 2 decades before we're going to get a handle on this. So with that, I'm going to let Dr. Samani talk. I really appreciate this time and you all listening to me. Thank you.
Thank you. And you're not going anywhere. We're just gonna compile this. So, just talking about American Heart Month because Go Women, Go Red for Women. We do have an American Heart Month presentation, which is from February, which is just 5 minutes. Just take a moment to listen to that. It's on the AKHB, the Smiley website too. And if you can move to the next slide, there is a session today. Dr. Kamruddin, can you move it to the next slide?
Oh, yes.
And we do have a session today at 4 p.m., which is ACA Open Enrollment Affordable Care Act. So please do join that if you are in need for insurance or healthcare coverage for the next year. And if you can move to the next slide, and I can take any questions that are on the chat, which I wanted to mention. So the first question is, You mentioned about HRT and breast cancer, contraindication there. But is it safe for individuals who have a family history of breast cancer but don't themselves have a personal history of breast cancer? Is that a contraindication?
No,
No.
it's typically, so a couple of things. One is, there's some bearing to whether you're BRCA positive or negative. That may weigh in a little bit, but in general, if you do not, and then there are these scores for breast cancer that are used to estimate your lifetime risk of breast cancer. And based on that, women are recommended mammograms versus MRI of the breast. If your score is very high, that may be a discussion, especially if you have family history of estrogen positive breast cancer. In those cases, there may be some discussion, but I think by and large, if you have a family member and you do not have currently diagnosed breast cancer and your breast cancer risk scores are minimal, there is no contraindication to hormone replacement.
Excellent. And I know it says the starting dose for HRT, but that will be individualized according to the medicine that you're
It
starting.
really is. It
Yeah.
really is. And I will say this, even though this is not my expertise, is that the current regimen of hormone replacement, the bioidentical hormones, are very safe overall, including the doses are smaller. That includes transdermal patches for estrogen. They are fairly safe. Unfortunately, we do not have very long-term trials in cardiovascular health at the moment. I actually don't see anything on the horizon as of now as well. So I don't know if we're going to study this a lot. My general perception and understanding of the data is that I think it's fairly safe for most people, and it should be used.
Correct. And I think recently the black box warning was also removed from HRT because of the same reason, because of this hesitancy that people have.
Yeah.
It's relatively very safe now to pursue HRT, should not suffer. And if you go back to earlier this year, we held a menopause session, and again, we emphasized on the need for HRT for women if needed. If you can go to your slide with the pyramid of the food,
Yeah.
there's someone, Shireen mentioned that you said that nuts and seeds were only twice a week, or where does it say that?
Yeah. Mm-hmm. Yeah,
Um,
it does
uh,
say that.
yeah, can you elaborate on that because that
Yeah.
seems less.
Yeah, I know. I don't know how stringent this has to be. For nuts, I will speak to that. Nuts are also heavy in total fat. So, the recommendation is like a fistful of nuts. I know a lot of people who are consuming a lot more nuts because they're saying it's heart healthy, and it's not true, right? Because, for example, there are different kinds of nuts. Cashews will be high in total triglycerides. Even though it's monounsaturated fat, it's not polyunsaturated fat, which is a better type of fat, but excess consumption leads to excess calories. That's what we have to remember. Now, I think legumes, I don't know if this is something that I can say, how a lot of this, as you know, any dietary study is observational. We do not have randomized trials to say what is good. There's so many confounders in anything that's recommended as there's so many problems in terms of the way research is done. Is I think this may be a little too stringent. I agree as far as the legumes is concerned. I think the thing about legumes that we have to remember is we're also consuming a lot of carbohydrate along with it. So the total amount of carbohydrate consumed is also important. Now, I'm not going to speak of the calorie consumption. The protein is about zero point 0.5 mg per kg. I think women in general consume a lot less protein, but it's also to control the carbohydrate content. I think that's partly the idea. I mean, you get some protein from vegetables, right? Asparagus, mushrooms, there, and lentils itself. But it's how do you balance that excess carbohydrate? And I think the bottom of the pyramid is more carbohydrate heavy, which is why they've put that.
Excellent. And there was also a question, what are your thoughts on water exercise? So you mentioned swimming, but many people do water exercises, or especially our
Oh,
older Jamati members where they're doing
yeah.
walking.
Oh,
Um,
that's fantastic. It's fantastic because you're adding more strength training on top of the water itself. And it's really low impact. It should not hurt your back, it should not hurt your knees. So, yes, very much recommended.
Excellent. And is there any data on COVID-induced hypertension in middle-aged women?
Yeah, I think there was a session that I was a part of a few months ago. What we do know is that post-COVID, we've seen patients where they first show high blood pressure right after COVID, and that is not to say it's because of COVID. It is more sort of unmasking of the underlying tendency to develop high blood pressure. It sort of is like a stress response that has triggered the high blood pressure. So it's not necessarily COVID itself. It's probably that you were at risk for high blood pressure, but because of the stress, and that can be true for several other sort of, events. After a major pneumonia, anything that causes severe inflammation may trigger and then bring front forth that you have risk for high blood pressure.
Great. And lastly, any recommendation for water intake? How much water intake is good?
Um, Yeah, I mean, overall, we talk about 8 to 10 glasses of water for healthy people. I think, we are extremely deficient in water, many of us. Um, we're yeah, obviously, in from our cultural perspective, we're more coffee and tea drinkers. So even getting to 10 glasses of water would be, again, if anybody in the Jamaat has congestive heart failure, and now even the new data doesn't support that they should limit their water intake. So water intake, 8 to 10 glasses is what's recommended. But it's also the way you intake the water. It's slow intake. You're not supposed to gulp water. You're supposed to take it in sips. But it keeps the metabolism up if you actually if you do continue to hydrate yourself. So because if you take water in large bulks, yep, the body just excretes it in the form of urine. So you have to take small sips and continue the water intake throughout the day.
Correct. Perfect. I think that's it for the. I had a question. Do pregnant women over a certain age need to be screened for heart disease, or is it just mostly based on symptoms during pregnancy?
Um, so it's so one, we focus on currently the standard of care is we focus on more on women who have high blood pressure during pregnancy. What I would suggest is talking it with your primary care doctor if you need to control symptoms because heart disease starts 3 or 4 decades before you actually get a heart attack or get congestive heart failure, right? You start to develop plaque very early. So in those people that have strong family history of heart disease, what we end up seeing is a lot of these women actually have abnormal cholesterol, a condition called familial hypercholesteremia, and that is why from college years they have high cholesterol. So managing your cholesterol pre-pregnancy is probably really important going into pregnancy to prevent certain complications related to the heart. Now you know that currently statins are not indicated. If you are pregnant, you can take cholesterol lowering medication. Um, but what you can do is modify your lifestyle pre-pregnancy, which includes, adequate weight, which is gonna decrease complications of the heart. So it's controlling your cholesterol, knowing that your blood pressure is normal, and things like that. The pre-pregnancy counseling can be very helpful going into pregnancy as far as heart disease is concerned. I will say that we do not have enough practitioners. We do not have enough preventive cardiologists in the country. We do not have enough primary care doctors that are focused on heart disease in women. So it can be hard to find someone who would know or have the knowledge and expertise to be able to treat you as such.
And I think Alela missed how much protein intake per day is recommended.
That was zero point 0.5 mg per kg.
per kg? Perfect. I think that's about it for the questions. Thank you so very much for this very inspiring and educational
Actually,
talk.
Sana, it's zero point
Yeah.
0.5 mg per pound.
Per,
Per pound.
yeah, because I think it's
Yeah,
1.2
yeah.
mg per kg.
Yeah,
Yeah,
that's
per
right.
pound, you're
It's
right, it's
per
half.
pound. And it's very hard to consume 80 to 90 grams of protein, and it's not easy.
No,
But yeah, I think from our cultural perspective, a lot can be achieved
of course.
through legumes and lentils. And I think, you know, when you do strength training, you actually do stimulate a lot of muscle growth, without which you can't stimulate muscle growth. So it's both. It's having adequate protein, but it's also being able to do exercises that build muscle.
That build the muscle. Correct, correct. Um, Thank you so very much for this educational talk. We really appreciate you taking out the time to share your knowledge with us
Thank
today.
you.
And the presentation has been recorded. It will be available on our YouTube channel. So yeah, thank you so much. Thank you, Dr. Kamruddin. Thank you, everyone, for those who attended.
Thank you for the opportunity.
Thank you. Bye.